Hi, good evening. Good evening, everyone. I hope the audio video is okay. All good. I can see the chat box, live chat. Okay, now the chat box is open right in front of me. Welcome to this FMGE Predictor series, okay, for this upcoming exam on this Sunday. Okay, so how is the preparation? Everything is going good? Okay, all good. Okay, so let's see, there are 25 questions. Okay, all these questions are like very high yield, and there are very high chances something from these topics will be asked in the exam. So let's see these questions one by one, little bit of discussion. Okay, 1 hour session, we'll try to finish it in time. Okay, so let's see, the answers should be coming from your side. Okay, I'll be discussing the questions and some of the solution. Okay, let's see. The singer complains of not being able to sing high notes following her thyroidectomy. What is the likely cause? So what is the reason that why this singer cannot sing on high notes, high pitch? Tell me. Maxillofacial injury made tracheostomy is the better answer, doctor. Okay, so what will happen if there is damage to the recurrent laryngeal nerve? Damage to the recurrent laryngeal nerve on one side. Okay, hoarseness of voice on both the sides, airway obstruction. Yes, your answer is correct. It is damage to the external laryngeal nerve or the superior laryngeal nerve. Okay, that is the correct answer. All of you, very good. This is the correct answer. Okay, another complication which can occur. Complications. Bleeding. Tell me, what will you do? Complications after thyroid surgery. Complications after thyroid surgery. Bleeding. So bleeding will present as airway obstruction. In the option, if you have endotracheal tube, that is the answer. Otherwise, open the wound bedside. Open the wound bedside. Then what else? Dyspnea could be a complication. Nerve injuries we had just discussed. Then hypocalcemia. Okay, that is because of removal or injury of all 4 parathyroids. All the 4 parathyroids. Yes, and one complication is thyroid storm. In which type of patient you will see thyroid storm? I mean, which patient you suspect or you expect it to be thyroid storm? Yes, in hyperthyroid patients who are not prepared for surgery. Not prepared for surgery. Okay, so this question, all of you are correct. These complications of thyroid surgery is a very, very important question. Almost all the exams ask question. Okay, so all good. Everything is fine. Yes. Let's move to the next question. The features of MEN syndrome. MEN is multiple endocrine neoplasia syndrome. Multiple endocrine neoplasia syndrome are. Just tell me 1, 2, 3, 4, 5. Okay, it is written 1, 2, 3, 4, 5. You just tell me which of these statements are correct. Pheochromocytoma is seen in MEN1 syndrome. True or false? Just tell me true or false. True or false? Statement number 1. Don't tell me the answer. Tell me each statement. Pheochromocytoma is seen in MEN1 syndrome. False. Why? Because pheochromocytoma is seen in MEN2 syndrome. Next option. Prophylactic thyroidectomy is indicated in MEN2 syndrome. Yes, true. In MEN2 syndrome. If it is MEN2A, it is done at 5 years. If it is MEN2B, it is done within 1 year. Red gene mutation is seen in MEN2. That is true. So tell me what is the gene mutation in MEN1. MEN1, what is the gene mutation? It is MEN1 gene. MEN1 gene. MEN1 is autosomal recessive condition. This is false. Okay, MEN1, MEN2, both MEN1 and MEN2 are autosomal dominant condition. Even MEN4 is also autosomal dominant. MEN1 gene is located on chromosome 10. False. In chromosome 10 there is ret gene. MEN1 gene is located on chromosome 11. So yes, false, true, true, false, 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 true, true. Option number B is the correct answer. Young adult patient, seminoma. Okay, so this is the answer. Okay, now just tell me 1 or 2 questions. Tell me what is the gene in MEN4 syndrome. Tell me the gene and the chromosome on which this gene is seen. Gene and the chromosome. Another question, most common pancreatic neuroendocrine tumor in MEN1. Most common pituitary adenoma in MEN1. Yes, gene is your correct CDKN1B gene. And chromosome 12. Yes, very good, very nice. Most common pancreatic neuroendocrine tumor in MEN1 syndrome. Most common pituitary adenoma in MEN1 syndrome. And tell me, a patient having mucosal neuroma and marfanoid habitus. Tell me the diagnosis. Most common pancreatic neuroendocrine tumor in MEN1 is non-functional. If that is not in the option, then the answer is gastrinoma. And most common pituitary adenoma in MEN1 is prolactinoma. Yes, very good, Srinadi. Prolactinoma. Marfanoid habitus, mucosal neuroma. What is the diagnosis? Yes, you're correct. MEN2B. Yes. Okay, nice. You know the things. Okay, so this is clear. No doubt. Anyone who has done just tell me who had done what question wrong and tell me what were you thinking so that we can see the problem and we can, do something about it. Next question. A 48-year female with primary hyperparathyroidism has a T-score of less than -2.5 on the DEXA scan, but otherwise she is asymptomatic. What is the next step in her management? The first thing is, this patient is having primary hyperparathyroidism. Primary means this could be either because of adenoma or hyperplasia or carcinoma. Okay, so first thing you tell me whether this patient who is asymptomatic, whether she needs surgery or not. She is having primary hyperparathyroidism, whether she needs surgery or not. So first thing we'll see is indication for surgery. Now if anybody remember, you can just tell me. Indication for surgery. Age less than 50 years. Serum calcium more than 12 milligram per deciliter. Decreased renal function, GFR less than 60 ml per minute. Okay, you are saying whether this patient needs surgery or not. Okay, let's see. Urinary calcium more than 400 milligram in 24 hours. And decrease bone mineral density on DEXA scan. On the DEXA scan, if the Z score or T score is less than minus 2.5 standard deviation, which is very nicely given in the question. Very nicely it is mentioned in the question. Just a moment. That the DEXA scan is this much. Okay, just a moment. Yes, sorry for this disturbance. Okay, all good now. So in this question it is given that she is having T-score of less than minus 2.5 on the DEXA scan. So this is one of the indication for surgery. This is, all these are indications. Okay, all these are indications. So definitely she is having indication. Now after the indication is done, now you want to do localization. So investigation of choice for localization. Answer is correct. Parathyroid localization study, so that you can go ahead and do the surgery. Investigation of choice for localization. Tell me. Technetium 99 sestamebe scan. There should not be any confusion. Very frequently asked question. Then you will do surgery. You will do minimal invasive parathyroidectomy. Means out of 4 glands you will remove this gland. Removal. How will you confirm? Osteoporosis में भी होता है, doc, not a problem. And these serum calcium is raised in n number of things. Age less than 50, half, 2/3 of the population, they are having less than 50-year age. Okay, so indication for surgery means in these people surgery is required. Okay, osteoporosis में हो, जिस मर्जी में हो, है ना, हमारा indication of surgery. Parathyroid में just 2-3 things are important. How to do the localization, what are the indications for surgery, and once you remove, how will you confirm the removal? Okay, so confirmation is either you go for a frozen section or you follow the Miami criteria. What is Miami criteria? Drop in serum PTH more than 50% of the baseline value 10 minutes after the removal. Okay, so these are very important things. Serum PTH more than 50%, 10 minutes after the removal. Okay, so parathyroid is very important, pheochromocytoma is very important, thyroid is important. Okay, so any confusion in this question? This is a patient we need, this is indication there are two things. She is also less than 50 years. Also her DEXA scan is less than minus 2.5 standard deviation. So this patient is definitely we have to go for surgery. So indication for surgery in asymptomatic patients are these. Otherwise, if the patient is having symptoms, then you have to do surgery. So either patient is having symptoms, but suppose patient does not have any symptom, but these things are there, then also we have to go for surgery. Okay, so that's why the answer is parathyroid localization. This is how you do localization. Then you go for a minimal invasive parathyroidectomy. And then the confirmation of the removal can be done by any of these things. Okay. Okay, next question. Here's a question. 22-year female evaluated for multinodular thyroid and recent history of terrible headaches and anxiety. Serum calcitonin high. FNAC shows this picture. What is your diagnosis? Tell me what is your diagnosis first. What do you think? Serum calcitonin is high. And this is picture. This is, I'll tell you if you cannot identify, this is amyloid stroma. So tell me what is your amyloid stroma? What is your diagnosis? Calcitonin, amyloid stroma. This is medullary thyroid cancer. Medullary thyroid cancer patient is also having terrible headaches and anxiety. So this could be pheochromocytoma. So pheochromocytoma, medullary thyroid cancer, it is MEN2 syndrome. MEN2 syndrome. Which of the following is the most important test to perform prior to any surgery? Before you go for surgery for medullary thyroid cancer, its first thing is rule out pheochromocytoma. So how will you rule out pheochromocytoma? Check the urine catecholamines. 24-hour urinary catecholamines. Okay, so many things are there in this question. You need to, join the dot. You need to know how to join these dots. Dots means the hints which are given in the question. Okay, 2A, 2B does not matter. Okay, in this case, you cannot tell whether it is 2A or 2B. It is MEN2 syndrome because these two things are there. It could be there in both. Okay, similar to this. Okay, just tell me what is the treatment of medullary thyroid cancer. Medullary thyroid cancer, remember in all the cases you have to do a total thyroidectomy. Plus level 6 lymph node you have to remove in all. Plus minus modified radical neck dissection. Why can't the answer be B? Serum parathyroid hormone level. Okay. Why do you think we want to rule out pheochromocytoma? We are not worried about even if the patient is having parathyroid. We are worried about pheochromocytoma because if there is a pheochromocytoma and you don't diagnose it, you take the patient for the surgery. During the surgery, BP will go such a high level that it can cause MI, it can cause stroke. Okay, so even if it is parathyroid, we are not worried about being parathyroid problem in a patient who is having medullary thyroid cancer. But any syndrome where pheochromocytoma is there, we are worried about pheochromocytoma because if you don't diagnose pheochromocytoma, it can cause death. If you don't diagnose parathyroid, it does not matter. Okay, so you understand why we want to do this. It might not be MEN syndrome also. It might be just pheochromocytoma. It might be something else, some other headache. But because it is a medullary thyroid cancer and it is associated with MEN syndrome, and MEN syndrome there is pheo also. So before you go for treatment of medullary thyroid cancer, it is better you rule out pheochromocytoma, because undiagnosed pheochromocytoma can cause death of the patient on table. Okay, so that's why the answer is that. Okay, tell me, see, these are the amyloid stroma picture. Some important picture, amyloid stroma in medullary thyroid cancer. Tell me, what does these pictures are showing you? What are these? What is this? This is orphan NEI nuclei, and these are Coma bodies. In MRND, which nerve to be preserved? Doctor, how many nerves you damage in neck dissection? In the neck dissection, only one nerve comes in the picture, that is spinal accessory. Okay, only one nerve comes in the neck dissection. Otherwise, there is vein, there is muscle. So if there is only one nerve, then what is the confusion? Orphan NEI nuclei, Coma bodies, these are seen in papillary thyroid cancer. Papillary thyroid cancer. Okay. Tell me the answer. Calculate the Glasgow Coma scale in a head injury patient who opens eyes to the painful stimuli, confused and localize the pain. Tell me, open eyes to the painful stimuli. What should I write in E? What should I write in V? And what should I write in M? What should I write? Modified radical neck dissection, removal of level 1 to 5 lymph nodes. In type 1, spinal accessory nerve, cranial nerve 11 preserved. In type 2, cranial nerve plus internal jugular vein preserved. In 3, cranial nerve, internal jugular vein plus sternocleidomastoid preserved. Okay. Okay, so yes, E, open eyes to the painful stimuli. What should I write? 2, yes, verbal response, confused. 4, localize the pain. 5, so 5 plus 4, 9 plus 2, 11 is the answer. Anybody, if anyone is having any confusion about GCS, tell me. This is one of the very, very important score which you should know. Eye opening, verbal response, and motor response. Eye opening, spontaneous 4, to voice 3, to pain or pressure 2, none 1. Verbal response, oriented, confused. Patient is speaking in words. Patient is producing sounds. No verbal response. Motor response, obeys command. Localize pain. Withdrawal to pain. That is same as normal flexion. Abnormal flexion 3. Abnormal extension 2. None 1. Mangled store, just remember what are the parameters. No need to remember the whole score. Okay, and there is one more thing, non-testable, non-testable, non-testable in all these 3. Okay, so this is the GCS. Okay, very important. Doc Talk, it is up to you. Okay, whatever you want to follow, you follow. This is what is written in the books, I told you. Okay, so this class is, I don't know, Doc Talk, whether you were there in our class or you are just like, you are doing this session for now. The sole purpose of this class is to, discuss some important questions, important topics in just one hour. Okay, we are not doing anything in detailed, discussion here. For that, we had done the classes. We had done the, revision in the form of DFX also. Okay, so this is just for that thing. Okay, so it's totally up to you. Whatever you want to believe, whatever you want to follow, you follow. But at least in this session, whatever part we are doing, remain focused to that. Focus on that thing. Okay, so this is something which you have to remember. I mean, even if there is any mnemonic or anything, that is not going to work. For GCS, you have to know GCS. Okay, Venkatesh Murthy, there is no trick, nothing. You need to remember this. And this is something without that, you cannot go to the, maybe exam if you don't know the GCS. Okay. Next question. A patient has got a blunt chest trauma, presented to the casualty with low BP, high pulse rate, engorged neck veins with muffled heart sounds. What is the most probable diagnosis? Yes, you will get the PDF. What is the most probable diagnosis? Muffled heart sounds, distended engorged neck veins, hypotension. Okay, this is this and this is backstride, and we all know backstride is seen in cardiac tamponade. Okay, this is cardiac tamponade. There is accumulation of the blood in the pericardial space. The heart does not get the blood sufficient. It will lead to, remember, obstructive shock. Okay, this is cardiac tamponade. On the fast investigation, which is a type of ultrasound, you can see the blood in the pericardial cavity. Treatment is you put a needle and aspirate the blood from the pericardial space, that is known as pericardiocentesis. Okay, so backstride, no doubt about that. Tell me the diagnosis in the next case. See this X-ray finding. This looks normal. What is this thing? You cannot see the black color thing, lung hair. In a case of trauma, this opacity, this is blood. Blood in the pleural cavity is hemothorax. Whatever thing is discussed in the class, everything is important. Why do you think we will discuss something which is not important in the class? I mean, what kind of question is that? If we had discussed that thing in the class, obviously it is important. Otherwise, you open any surgery book, the notes are maybe 200, 300 pages. The books of surgery are 1500 pages, and that too very small letters are written in that. So if something was told in the class, why do you think we will tell you something which is not important? Okay, so obviously it is important, very important. There are very high chances you will get a question on that. Okay, it is very important. Hemothorax. Okay, the treatment of hemothorax is you will put a ICD, intercostal chest tube drainage. What is the site where you will put the ICD? Okay, 4th or 5th intercostal space, just anterior to mid-axillary line. And you can see at the upper border of lower rib. Upper border of lower rib. Another safe area, you can see this is this area we are talking about. Yes, triangle of safety. What are the boundaries of triangle of safety? This is triangle of safety. Okay, what are the boundaries? Pectoralis major, lateral border. latissimus dorsi, anterior border, and the horizontal line at the level of nipple, or you can say fifth intercostal space. No, ICD always goes Prajapati Saurav in the second intercostal space. I mean in the fifth intercostal space only, fourth or fifth. There is no other site of ICD apart from this. This is the only site for ICD, whether in kids or in adults. This is the only site of ICD. Indication for surgery: more than 1500 ml of blood comes out immediately out of ICD, or more than 200 ml is coming hourly for 2 to 4 consecutive hours. Okay, what do you think is the diagnosis in the next image? Yes, upper border of lower rib. Gagan, this is, suppose this is the fifth intercostal space. Suppose this is the fifth intercostal space. So you can go from here also or from here also. But if you see the ribs at the lower border of the upper rib, there will be neurovascular bundle. So that's why that is not the safe area. Safe area is this, because there is no neurovascular bundle here. This picture, you can see this X-ray. This is jet black air. So that is actually pneumothorax. Pneumothorax. Okay, this looks normal. This is pneumothorax. See, pneumothorax on E-fast. E-fast is extended fast. See, in fast we put the ultrasound at these 4 places. These are for fast. In E-fast we'll put the ultrasound at these chest area also, then it becomes E-fast. Okay, extended fast. Extended fast. So on extended fast, this seashore sign, can you see the seashore sign? Seashore sign is a feature of normal lung. There is something known as barcode or stratosphere sign. These are seen in pneumothorax. Barcode or stratosphere sign is seen in pneumothorax. Okay, so pneumothorax, if it is a closed or simple type of pneumothorax, then we can put a simple ICD. If it is a open type of pneumothorax, 3-sided dressing first and then we will put ICD. But if it is a tension pneumothorax, then first you put a needle and then you put the ICD. Now this needle which we are putting, in case of adults it will go in the fifth intercostal space mid-axillary line, but in children this needle will go in the second intercostal space mid-clavicular line. Okay, so this is about thoracic trauma is very important. So I'm just quickly, discussing important thoracic traumas. So this is a treatment of pneumothorax, 3 types. What is your diagnosis in the next case? Just see, some ribs are fractured and these fractured segment has paradoxical movement. Tell me the diagnosis. Paradoxical movement. What is the diagnosis? Multiple rib fractures. Anybody? What is your diagnosis? Okay, just a moment. Flail chest, yes, very good. Flail chest. Important thing about treatment: no respiratory distress, oxygen by mask, and analgesics. If the patient is having problem in the breathing, respiratory distress, endotracheal tube, and intermittent positive pressure ventilation. Yes, this X-ray may be not very nicely seen, but there is stomach seen in the thorax. Okay, so that is diaphragm injury. Diaphragm injury more common on the left side as compared to right. No ICD. Don't put ICD. Treatment is surgery. No ICD placement. Yes. Okay. Going to the next question. I guess we should remain focused to the question. We should not discuss that much. Yes. Okay. All these things you will get. Okay. All this, everything, the written PDF you will get on our app, eMedicoz app. So don't worry if you cannot see anything. Yes, ICD is contraindicated. No ICD. Surgery should be done. Regarding estimation of the body surface area after burn, all are true except. Tell me, in children, estimation of the burnt out area is calculated by using Lund-Browder chart. That is the correct statement. Rule of palm 1%. That is also true. In adult, rule of 9. That is also true. Groin area equals to 5%. That is wrong. That is wrong. Option number A is wrong. Groin area is maybe 1% or less, because 1% is the area that is equal to the hand. So that is probably 1% or little bit more. 5% is for the gluteal area. Okay, 5% is both the buttocks are like gluteal area. Okay, so see, this is rule of 9. In case of adults, okay, 18% in the front, 18% in the back. Upper limb is 9%, lower limb is 18%. Okay, head and neck area is 9%. In children, there are a bit things are different. This is 18%, and the lower limb is 13.5%. Rest is same as adults. First degree burn is not included in percentage. Yes, anterior abdominal wall and the anterior chest wall. See, this is the chest and this is the abdomen. That is 18%. And back of the chest and back of the abdomen is also 18%. Okay, see, this is already I have given first degree burn. Injury occurs to the epidermis, just redness. See, superficial second degree. Can you see the blisters? Deep second degree. Can you see mottled pink or pale? Third degree, eschar, either it is white color or black color. And fourth degree, when it reaches to the bone. And for calculation of fluid calculation, these are the formulas. For adults, 2 into weight into percentage. For children, 3 into weight into percentage. And for electric one, 4 into weight into percentage. Okay, so I'm sure you know these things because these are like very basic things and one should be knowing these things before going to the exam. Yes, Shubham, very good. This is as per the ATLS guidelines. Okay. Next question. Quickly diagnosis. Elderly female, ulcer over the anterior medial aspect of the lower limb. It is flat, edges sloping towards the center, seropulent discharge. No trauma. And she is having varicose vein for years and she noticed that this area is now brown in color. This is the site. Tell me what is your diagnosis. What is your diagnosis? Look at this and tell me what is your diagnosis. This is undoubtedly venous ulcer. All of you are sure? Venous ulcer. Gator's area, medial aspect of lower 1/3 of the leg. Okay, see, in the ulcer, in the leg ulcer, you need to see the site. This is very typical of venous ulcer. And I see dorsum of the foot and a tip of toes, Webb's area. These are features of arterial ulcer. Then see plantar aspect, pressure areas. These are the sites for trophic ulcers. So looking at the ulcer itself, you cannot tell that which is this ulcer. You need to see the site. In the lower limb ulcer, you need to see the site. And I have given you the important sites. Okay, where is the arterial ulcer, where is the venous ulcer, and where is the trophic ulcer. I hope it helps. Yes. Next question. Male patients come with complaints of severe chest pain. CT of the thorax is given. A bit difficult question, but if you have read the notes, you can tell me. More hint I will give you in this question. Patient is a known case of hypertension. Severe chest pain is interscapular, between the two scapula. And now you can see this finding. Tell me, what is your diagnosis? So first, see, for any question, even in the exam, when the question comes, first you try to tell yourself what is the diagnosis. And then, yes, other things are there. Aortic dissection. Yes. So what are the different types of aortic dissection? See, this is DAMS-eMedicoz classification. DAMS 1. Dissection starts from the ascending and going into the descending aorta. DAMS 2. Starts from the ascending and goes up to the origin of major vessel. And DAMS 3. Starts after the origin of major vessel and going into the thoracic aorta or even abdominal aorta. So if it is limited to thoracic aorta, it is A. If it goes to the abdominal aorta, it is B. Yes, DAMS classification. That is also as per the Stanford type A and type B. This is as per the Stanford classification. Type 1 DAMS is the most common. Yes, so what is the treatment? Initial treatment is short-acting beta blocker. Okay, like esmolol. After that, for DAMS 1 and 2, we need to go for surgery. For 3, basically non-operative management, antihypertensive. So majority of the patients, the surgery is required. So option number C, surgery is not required, is the false statement. Hypertension is the most common cause, correct. False passage in the tunica media, that is correct. Most common site is ascending aorta, that is also correct. The question is false. Okay, they are asking what is false about this condition. False. Obviously, surgery is not required. What to mark, esmolol or landy? What was that thing? Landilolol. Okay, see, as surgeons, we are not like medicine people or pharmacologists. Surgeons knows just 2-3 beta blockers: propranolol, atenolol, metoprolol. That's it. Okay, whatever landilol or pandilol, these things are out of surgery, pursuit. So answer should be esmolol only if they ask. Okay, there is nothing like landilol. I mean, there will be some beta blocker. Whatever beta blocker they give, you mark that thing. Okay, the exam, the question will be of surgery. Newer drug, maybe if they ask new drug and the drug of choice, that is a different thing. Okay, surgeons, as far as I know, surgeons, they don't know that something like landilol or whatever bandilol has come to the market. Okay, so short acting beta blocker, whatever, as per the surgery, if the question is made by a surgeon, which will be there, so you mark esmolol. Okay, don't go for these things. Don't try to be too fashionable, too glamorous, don't apply too much of your mind in the exam. That if you try to become more smart in the exam, believe me, examiners will give you second chance to sit in the exam. Okay, so don't try to be over smart when you're sitting in the examination room. The whole life is there to act smart and to do all those things in the exam. Just be very average. Think like an average student. Mark like an average student. Believe me, you will pass like the topper. But if you think complicated, complex like a topper during your exam, like I said, you will get second chance to sit in the exam. Okay, so C is the answer. Okay, this is just the CT scan to show this is type 1 because there is here and here both side dissection. This is D by case 2, only this area dissection. This is D by case 3, only this side is the dissection, descending aorta. Okay. All are true about necrotizing fasciitis, which is shown in the figure, except this is a polymicrobial synergistic infection. That is true. In 80% of the cases, some history or trauma, something is there. Yes, mortality rate is quite high. This is not a surgical emergency. This is a surgical emergency. Okay, you need to act very fast in necrotizing fasciitis. Okay, yes, B is correct. Okay, some few people I can see they are marking most the answer. Shubham, Shrinadi, Nahimon. I can see that most of the answers what you are saying is correct. See, necrotizing soft tissue infection, necrotizing fasciitis. Most common cause, Streptococcus pyogenes. Same kind of necrotizing infection on the abdominal wall. Melanese gangrene, caused mainly by Enterococcus. And I'm sure all of you know in this perineal area, the infection is Fournier's gangrene. The organism is E. coli. Okay, in all these cases, the treatment is as early as possible debridement, antibiotics, and hyperbaric oxygen therapy treatment. Yes. Okay, so it is a surgical emergency, carries high mortality. First line treatment for the following condition. Very straightforward. I want everyone to mark this correct. What is your diagnosis? See, there is some abnormal scar which is raised and which is also outgrowing the original area. So undoubtedly this is keloid. Keloid. Testis is spared, yes, in Fournier's gangrene. They are all types of necrotizing soft tissue infection. Okay, necrotizing fasciitis will call when it is into the extremities like upper limb and lower limb. All these are necrotizing soft tissue infections. Intralesional injection of steroid. Yes, correct. What steroid? Tell me the name. Triamcinolone. Okay, this is keloid triamcinolone. Okay, so this is a very typical appearance of keloid, and this is the typical appearance of hypertrophic scar. Yes, keloid is familial, racial. It is seen mostly in colored people as compared to white skinned people. Okay, it outgrows the original boundary. Pain, itching, recurrence is common in keloid. These things are not there in the hypertrophic scar. These things are not there in the hypertrophic scar. Okay, so this is keloid. Yes, sternum is the common site. Okay, this question. The lesion of the oral mucosa which is considered to carry the maximum risk of malignant change. Now I want answer from you people. How much you were attentive in the class? Tell me, the lesion which is considered to carry maximum risk of malignant change. Speckled leukoplakia, erythroplakia, mucosal is almost no risk, ulcerative gingivitis. Tell me, both Prajapati, both keloid and hypertrophic scar, they have both the types of collagen. Type 1 and 3 is there in both. Yes, speckled leukoplakia. Speckled leukoplakia, maximum risk. Maximum risk. After that comes erythroplakia. Okay, so dog talk, please correct yourself. Speckled leukoplakia has maximum chance of turning into malignancy. Speckled leukoplakia is basically a lesion where inside it is white in color and the periphery will be red in color. Okay, so that is also known as erythroleukoplakia. Previously, 2 years back, the answer was erythroplakia, but now speckled leukoplakia has a maximum risk. Okay. This question, let's see how many of you have got this correct. 3 by 2 centimeter breast cancer attached to the pectoralis major, and there are fixed and matted axillary lymph node on the left side and mobile axillary lymph node on the right side, which is also malignant. What is the stage as per the TNM? I told in PYQ Kebab that if we compare erythroplakia with speckled leukoplakia, erythroplakia and leukoplakia, erythroplakia is more. But see, leukoplakia are of two types. Okay, let me tell you something. Leukoplakia can be homogeneous and heterogeneous. In the heterogeneous comes speckled and nodular type. Okay, so if you compare a erythroplakia with a homogeneous leukoplakia, obviously erythroplakia is having more risk. Okay, but okay, if that will help you, speckled leukoplakia, then erythroplakia, and then homogeneous leukoplakia. Okay, so it should be speckled. If they have not mentioned the word speckled, then obviously erythroplakia is having more risk. Okay, so 3 by 2 centimeter. Let's see T staging. T1 less than equal to 2 centimeter. T2 more than 2 to 5 centimeter. T3 more than 5 centimeter. T4A. This T4A, chest wall involvement. That is involvement of ribs, intercostal muscle, serratus anterior. Only these things. T4B, skin involvement. Okay, ulcer, pudi orange, and satellite nodule. Only these things. T4C is both A plus B. and T4D is inflammatory carcinoma. Now, a very important feature of inflammatory carcinoma is PUD orange involvement is more than 1/3 of the skin. PUD orange is involving more than 1/3 of the skin of breast. Okay, so that's why if PUD orange is involving less than 1/3 of the skin, that will be T4B, but if it involves more than 1/3 of the skin, that will be T4D. Okay, similarly, N1 is ipsilateral mobile axillary lymph node. N2A is ipsilateral fixed or matted, which is given in this question, axillary lymph node. N2B, ipsilateral internal memory without axillary. N3A, ipsilateral infraclavicular, that is apical lymph node. N3B, ipsilateral internal memory with axillary lymph node. And N3C, ipsilateral supraclavicular. M0 is no distant mets, M1 is distant mets. Remember, if contralateral lymph node involvement, that is considered as M1. Okay, so what is given in the question? In the question it was mentioned that yes, 3/2 centimeter pectoralis major is not involved, so it will be T2. Fixed and matted axillary lymph node on the left side, it will be N2, N2A to be more specific, and right axilla is also involved, so contralateral lymph node is also involved, so it will be M1. Answer is D. All of you are correct. It is D. The most important TNM staging for your exam. Okay, breast cancer. All are true about inflammatory bowel disease except ulcerative colitis is, just tell me the options are true or false. Ulcerative colitis is limited to colon and rectum and extends into mucosa and submucosa. This is correct. Crohn's may involve any part of the GI and it is all the layers. Correct. Most investigators believe, although the exact cause is not known, but they believe that it is because of alteration of the host interaction with the intestinal, aberrant mucosal immune response. That is also true. Now see the option. The presence of multiple separate sharply delineated area of disease resulting in skip lesions is characteristic of ulcerative colitis. This is wrong. Yes, you are correct. D is the answer because skip lesions are seen in Crohn's disease. Skip lesions are seen in Crohn's disease. So this is very typical of ulcerative colitis. In all the cases, rectum, the ST starts from the rectum. Starts from rectum. It can involve the whole colon or maybe terminal ileum. Okay, it is only mucosa and submucosa. Okay, superficial. Maybe you can see pseudopolyps. Okay, and it is contiguous, continuous lesion, continuous, no skip areas, no skip lesions. But if you see Crohn's disease, can you see Crohn's? Any part, okay, important things, all the layers, transmural, all layers are involved. Okay, initially there is ulcer. Then there can be deep ulcers, cobblestone appearance, some normal areas in between, skip lesions. You will see granuloma, non-caseating granuloma. You can see the mesenteric fat is going on the intestine. Mesenteric fat on the intestine. Rectum is not involved. Okay, rectum is spared. But yes, in 30% of the cases there can be perianal disease. Perianal disease involvement like abscess, fistula, these things can be seen. Megacolon can be a complication seen in ulcerative colitis. Okay, that is a complication. That is a complication. Aphthous ulcers are seen, Shubham, in intestine only. Aphthous ulcer is superficial ulcer. Okay, so it starts as a superficial ulcer in the intestine and then it becomes more deep ulcer. Okay, so these are some of the important differences between Crohn's and ulcerative colitis. Which statement is true of the following intestinal disorder? And with a green arrow it is shown the disorder. I can enlarge it if it helps you to see. What is this part? Yes, aphthous ulcer is Prajapati, that is superficial ulcer, but not in the oral cavity. That is there in the intestine only. The intestine, in intestine it starts as superficial aphthous ulcer and then they become deep ulcer. Okay, it's not that the Crohn's disease starts as an oral ulcer in the mouth. Okay, it is aphthous means superficial ulcer in the intestine only. Yes, this is Meckel's diverticulum. Yes, very good. So tell me which of this statement is true. Okay, they are asking true. Remember in the exam, like I am doing, make sure you know what they are asking in the question, whether they are asking true thing or false thing. Many students, they do this mistake. Okay, the question is about true and they mark the false statement. Be double sure before you mark that what is the question, whether they are asking the correct statement or the incorrect. It is present in 20%. No, it is 2%. Arises from the mesenteric border of jejunum. No, it is from the anti-mesenteric border and that too of ileum. May contain heterotopic pancreas. This is true. Present only in males. No, it is more common in males, but it is seen in females also. Heterotopic, most common, it is stomach, then pancreas, then colon. These three mucosas are seen. Yes, 2% of the population, 2 feet from the ileocecal junction, 2 inches in the length. Staph aureus, you are absolutely correct. How stupid it is to, call you Staph aureus and dog talk and all these things. Why can't you write your names? And I mean, what are you so ashamed of? If you are like the genuine person, I don't find any reason to, hide yourself or, you are giving these names to yourself. Okay, it's your choice, your life, whatever. Those Gen Z, it's up to you. Okay, so this is, see, this is the typical, I'll show you different images of Meckel. So this end, see, this part is from where the mesentery is there. That is the mesenteric end. It arises from this end which is free. That is anti-mesenteric. Okay, 2 inches in length from the, you can see this is the mesenteric border. It is not coming from here. It is coming from the anti-mesenteric border. Okay, so that is Meckel's diverticulum. Although not related to the question, but this is also a very important image. Tell me, what is this finding? What is this diagnosis? A part of the intestine is going into another part of the intestine just adjacent to it. Tell me your diagnosis. Into susception. The part which is entering is into susceptum and the part which is receiving is into suscipiens. Yes, Avnish Yadav, welcome to the class. Okay, yes, into susception, very good. What findings you will see on the imaging? See, on this barium, enema, and on this X-ray, this is X-ray, they call this as meniscus sign. On the barium enema, they call it as claw sign. Yes. This is the ultrasound. They call it as target sign on a transverse scan. On a longitudinal scan, this is pseudo kidney sign. Okay, so some of the important images related to the intussusception. Very important question. This is also intussusception on the CT scan. On the CT scan. Same, that target sign only. Here also it is known as target sign. Yes, very good. Mark the correct statement regarding the image shown below in a patient of dysphagia. Okay, this is a barium swallow image in a patient of dysphagia, but can you see the arrow is also showing some abnormality? First tell me what is your diagnosis and then we'll discuss the things. What is your diagnosis based on this? Okay, this is question on Zenker's. This target sign can be seen in CHPS also. Zenker's diverticulum. But if they ask target sign and you have intussusception, that is the better answer. Okay, target is what? There is something like on the, if you have seen a dart game and all, they have like these things. Okay, that center part is the bullseye. So that is target. Zenker's diverticulum. So tell me the option. It is more common on the right side? No, it is more common on the left side. It occurs below the cricopharyngeus muscle. See, where does it occur? From where does it arises? Zenker's diverticulum from the Killian or the Killian's triangle. What is Killian's triangle? These muscles, inferior constructor muscle, these are known as thyropharyngeus, and this is cricopharyngeus, and this part is the Killian's triangle, and the diverticulum arises from here. So obviously it is arising above the cricopharyngeus, not below. It is a traction diverticulum. No, it is a pulsion diverticulum. Zenker's is a pulsion diverticulum. So basically in this area there is increased pressure, and because of that increased pressure a part of the mucosa comes out. Okay, so Zenker's diverticulum is a false diverticulum because only mucosa comes out, and the key principle in the management is cricopharyngeus myotomy. That is the correct statement. Okay, if there is an area where there is increased pressure, if you cut few fibers of cricopharyngeus, the increased pressure is gone, and now that patient will be fine. So less than 2 centimeter, if there is, this Zenker's diverticulum, then only cricopharyngeus is good enough. Only cricopharyngeal myotomy is good enough. Yes, otherwise the treatment is diverticulectomy with cricopharyngomyotomy. Yes, that is correct statement. See, cricopharyngeus myotomy has to be done in all case. If the diverticula is less than 2 centimeter, then this only is good enough. If it is more than 2 centimeter, then along with this you can go for either diverticulectomy or diverticulopexy. But this too you have to do. Cricopharyngeal myotomy you have to do. Okay, some problem in the voice. Some issue in the voice. Let me talk to the concerned. Voice is okay. If you want, I can speak in more higher volume. If it is low, then I can increase my voice, but I hope it will be okay. Okay, you can rejoin. So that is the answer. Option number D. See some more things. You see some more things. This is a barium swallow. This is normal. On the barium swallow, This is normal esophagus. Tell me what is your diagnosis. Tell me that diagnosis on this. This is esophagus. This is esophagus. Very hugely dilated. Okay, these signs are known as what? Bird beak, rat tail sign. This is a feature of eclasia cardia. Eclasia cardia, yes. What is this? Corkscrew esophagus. Corkscrew esophagus. Diffuse esophageal spasm. Diffuse esophageal spasm. Say this. Irregular filling defect. Irregular filling defect. Apple core appearance. These are features of carcinoma esophagus. Carcinoma esophagus. Okay. Which is the most common metabolic abnormality post-gastrectomy? The common metabolic abnormalities post-gastrectomy is iron deficiency, vitamin B12 deficiency, and calcium deficiency. Remember these three, and the most common is iron deficiency anemia. Okay, nothing much to discuss, but this is important thing that after you do a gastrectomy, these complications are common: iron deficiency, vitamin B12 deficiency, and calcium deficiency. Okay. All of the following are correct about the following anomaly except. What is this anomaly? This is horseshoe kidney. Both the kidneys are fused. Okay, this is horseshoe kidney. This image is, I guess, upside down in your thing. This is important. Horseshoe kidney. So horseshoe kidney are fused. What is the question? Correct except. So basically they want to ask the false statement. Horseshoe kidneys are fused by their caudal poles. Yes, mostly the inferior pole. They get hung up on their inferior mesenteric artery. That is also true. They require division and replacement in correct position. That is a very obvious false statement. That is our answer. Ureterus cross anterior. That is also true. Okay, yes, the division is not required. The only condition where it is required is hysterectomy. Okay, so this is horseshoe kidney. Okay, usually this part which is known as isthmus, that is present at generally L4 vertebra level. Inferior mesenteric artery prevents the ascent of this. Ureters, they cross anteriorly. So if they are crossing anteriorly, that makes it angulated, and that will cause stasis, hydronephrosis and all. On the IVP, this picture is known as flower vase appearance. Flower vase appearance or hand joining sign. Yes, correct. More things we'll discuss, some more images we'll discuss. Just a moment. Next question. Stone which is resistant to lithotripsy and crystals of that stone in urine is shown in the picture. Tell me, what are these stones? Type of stone which is resistant. Lithotripsy means ESWL, extracorporeal shock wave lithotripsy. That is same thing. And it is hexagonal in the microscopy. Yes, all of you are correct. Cystine, very hard stone. Okay, stones resistant to lithotripsy. Cystine. Calcium oxalate monohydrate, then brucite and hydroxyapatite. Those are calcium phosphate type of stones. Okay, so Staff Aureus is saying PUV and vesico-ureteric reflux ki clinical picture. Clinical picture means vesico-ureteric reflux. The problem will not be in the micturition. Okay, the problem will be in vesico-ureteric reflux. The urine is going back into the ureter. That is vesico-ureteric reflux. In posterior urethral valve, there is some valve below which the urine cannot go properly. Okay, below these valves. Okay, so mostly this posterior urethral valve can be diagnosed in the antenatal period. Okay, so tell me these different shape. Dumbbell shape, yes, dumbbell shape. What is your diagnosis? Calcium oxalate monohydrate. Envelope shaped, calcium oxalate dihydrate. These coffin lid shape, triple phosphate. Hexagonal, cysteine. Needle shape, brucite. And amorphous is uric acid. Okay, so these are the different shapes of crystals in the urine. Identify the drain shown in the image. This is a drain shown in the image. What is the name? Okay, I'm sure all of you know Jackson-Pratt drain. Jackson-Pratt. Okay, I'll show you. See, this is a corrugated rubber drain. This one is Penrose drain. They are types of open drain system. This is abdominal drain, also known as Robinson, but abdominal. This is a closed non-suction drain. This was our question. Jackson-Pratt drain. And this is Romovac drain. These are closed suction drain. Okay, so what is open drain, closed drain? In closed there is closed non-suction and suction. That question is straight away Jackson-Pratt drain. Okay, next question, although very easy, it looked big. There is bleeding for 2 months and no pain, diarrhea, constipation. Colonoscopy reveals 2 cm mass, 1 cm from the anal verge. No lymph node. Biopsy shows squamous cell carcinoma. CT and everything is fine. So 1 cm from the anal verge is squamous cell carcinoma. This is anal canal cancer. And what is the treatment of anal canal cancer? Treatment, if you remember, it is chemoradiation, also known as Negro's regimen. So option number D. Chemotherapy. No, this is, yes, chemoradiation. Chemo and radiation. Chemotherapy, 5-fluorouracil and mitomycin. Okay, if after this there is recurrence or there is residual disease, then we'll go for abdominoperineal resection surgery. Okay, only if after chemoradiation there is recurrence or residual disease, then we go for APR, otherwise Negro's regimen. Lateral internal sphincterotomy is done for the anal fissure. This does not look like anal fissure. It was a cancer. 25 female, history of intermittent flank pain and hematuria. What is the significant radiographic sign demonstrated on this? And what is the most likely diagnosis? Okay, so can you tell me what is the sign in this IVP investigation? If you give focus distally, this is cobra head or adder head sign seen in ureterocele. Yes, ureterocele. Okay, tell me some of the signs. What do you think is the diagnosis in this image? Can you see both the kidneys are on the same side? Okay, so that is unilateral fusion of kidneys. In the other image, can you see there is one ureter? Okay, one ureter and another ureter. This is duplication of ureter. In duplication of ureter, one more sign you can see. Can you see this? This is known as drooping lily sign. So suppose they ask drooping lily sign is seen in which condition? It is duplication of ureter. Okay, in duplication of ureter, remember something known as Weigert-Mayer's law or rule. Okay, I'm not going to discuss here, but you should know what is this. Another IVP showing something on the right side, something like reverse J appearance. That reverse J appearance is seen in retrocaval ureter, reverse J or fishhook appearance. This is polycystic kidney disease, spider leg appearance. Spider leg appearance, polycystic kidney disease. This is a plain X-ray showing a renal stone on this side. Yes. Okay. 3 CTs and tell me the diagnosis. This is CT number X, this is CT number Y, this is CT number Z. Anybody? Tell me what is your diagnosis? These 3 CT scans. What is this thing? If you can see these air foci in the kidney, right kidney. This is emphysematous pyelonephritis. What is this white color thing? This is cement kidney or putty kidney. This is renal TB. And what is the diagnosis here? Very nice. You can see NCCT-KUB showing a NCCT-KUB showing a renal stone. Yes. Okay. A 55-year-old man diagnosed with BPH and pharmacological treatment was not helpful, so TURP is being planned. Which of the following is the most common complication of this procedure? Transurethral resection of prostate. Pharmacological treatment can be given by alpha blocker, especially alpha 1A and 5-alpha reductase inhibitor. Yes, retrograde ejaculation is the most common complication. All of you are correct. Okay, when we do TURP, okay, there was some image I was trying to put, but okay, fine. Retrograde ejaculation is the most common. In TURP, there is one complication that is known as TUR syndrome. The TUR syndrome is seen when you use a hypotonic irrigating solution like distilled water. Distilled water, if you use for the irrigating solution, that will cause dilutional hyponatremia that can lead to brain edema and increase in the intracranial pressure. Patient can have hypertension and bradycardia, visual problems. Yes, TUR syndrome. Mainly remember something, it is because of hyponatremia, decreased sodium. Okay, second last question. All of the following statements are true of testis except, so basically they are asking which is the false statement. They want to know which is the false statement. Most common between 10 and 25 years of age, that is true. Prompt exploration and twisting and fixation is the only way to save, that is also true. You have to do surgery as early as possible. Inversion is a common predisposing cause, yes. Anatomical abnormalities, unilateral and contralateral testis should not be fixed. That is absolutely wrong. It should be fixed. Okay, see, this is how the torsion occurs. Okay, so when you open up the patient, see, this testis is healthy. If this testis is healthy, you do the detorsion and bilateral orchidopexy. You fix it, otherwise it will rotate again. Now see, this testis looks gangrenous when you open up. So now you will do surgery. You will do removal on this side plus contralateral orchidopexy. So you have to fix the other side also, because whatever is the abnormality, this will go on the other side also. Signs of the torsion is there will be pain, the testis will be higher up, there will be loss of cremasteric reflex. Okay, that prehens sign on which you, when you elevate the testis, if the pain decreases, that is epididymoarthritis, and if the pain remains same, that is torsion. That is not very it is very least sensitive and specific, so that is clinically not very important these days, that prehens sign. Okay, prehens signs you are asking, or some other sign? Okay, the only clinical sign is prehens sign, but Doppler is the better thing. When the person comes with acute pain in the testis, you just elevate that testis using, give some support, elevate the testis. If the testicular pain decreases, it means it is epididymoarthritis. If it does not decrease, remains same, it means it is torsion. Okay, this is prehens sign, but like I said, it is not very sensitive and specific. Tubercular ulcer, from outside you cannot tell that it is tubercular ulcer. Okay, so just remember those things. Okay, the last question, and then we'll end. We were supposed to finish it by 7, although the class started 15 minutes late, but still the session extended. Male patient, abdominal pain, fever, nausea, vomiting, BP is low, pulse rate is high. What is the chest X-ray is showing in this image? It is shown with the help of arrow also. Arrow. Okay, you are asking TB ulcer transverse rahega. TB ulcer, where you are asking, in the intestine or in the otherwise? Okay, so intestine में तो see, intestine typhoid ulcer. Okay, typhoid ulcer, TB ulcer. Okay, out of the context. See, tie, how we put the tie? It goes longitudinal. Okay, we don't put the tie transversely, longitudinal. So tie, just remember, typhoid mein tie. Tie is longitudinal, and the other one is transverse. Yes. Okay, so this is free gas under diaphragm. Free gas is a feature of, this is like very typical. You have to see on the right side, free gas. That is a feature of perforation of hollow viscera. Perforation of hollow viscera. Okay, so in the patient of perforation peritonitis, although laparotomy is required, but What is the immediate management? Immediate management is this. You first resuscitate the patient. Your patient is having shock, hypotension, tachycardia. First you give IV fluids, antibiotics, and then you take the patient for laparotomy. Okay, in Boerhaave mein vitals and hypotension. See, in Boerhaave syndrome, vitals will be definitely poor. That can be seen in Malrivis also. In Malrivis, if there is too much of bleeding, the vitals can be gone there also. Boerhaave mein pneumomediastinum hoga. Yes, correct. Okay, so these were some of the important questions in the Predictor series. Now I will say best of luck for your upcoming exam. You have read well. I can see your comments. I can see your enthusiasm. You know the things, and I'm very sure you will do great in the exam. Like I said, don't think too much in the exam. Don't try to make it overcomplicated. The questions will be simple. Mark the answers also in a simple manner. Don't overthink. Don't leave anything. Okay, usually people, they don't leave anything. There will be image based questions. There will be clinical based. Read the question carefully. You will have enough time, good enough time to read the question twice, read the option. Don't do this mistake that they are asking the true statement and you are marking the false statement. Okay, be very, very careful about these things, and the exam will be very, very easy for you. Refeeding syndrome, if you are asking, refeeding syndrome is a topic which generally takes 10-15 minutes. I will just tell you one thing: hypophosphatemia, hypokalemia, hypomagnesemia. These 3 electrolyte abnormalities you remember. Okay, refeeding syndrome itself is a complication. Okay, Adil Tube, it is a complication of TPN. Okay, so these are the things you will see in the refeeding syndrome. Okay, thank you very much, and we'll meet again. We'll meet again on the day of the exam as a recall session, and also when you pass that exam and get the great marks, we'll meet again in the post-exam celebration, result celebration. Thank you very much. Yes, most common is hypophosphatemia. Okay, thank you. I wish you all the very best for your exam. Thank you. God bless you all.